That one before, John. Real novel. All right, thank you for the invitation to talk here. It is unfortunate that I'm speaking after Dr. Gowan, who has literally the most soothing MPN voice I've ever heard. And I'm an annoying New Yorker who's going to come to you and talk about new drugs for MPN. So really sort of the centerpiece where the integrative oncology integrates. So what I'm hoping to accomplish today through this talk is to excite you and to provide some degree of hope and vision of where things are going. And what I've done, and because it's only 30 minutes, what I've done, I know everyone's had this problem, so to advance to the next slide. Is it forward or? It should be the right arrow. Okay. So here's the agenda for today. So we're going to talk about monotherapies for MF. And the reason why I'm doing that, monotherapies meaning a single agent, is because Naveen Pemaraju later on is going to talk about combinations, which is really important and what I think is really the future of MPN therapy. I picked two therapies to talk about that are in phase 3 testing. So these are late stage. This is like the point where they may be evaluated by the FDA for approval and then be globally and commercially available. So I picked these two because they are single agents and they are in the latest stages of development. And then I picked actually this, I don't know if this is the updated slide deck. This looks like the original slide deck. I made a shorter slide deck. So I'm not going to talk about selinexor, which is a really interesting drug because I don't have time. I'm going to highlight a PIM1 kinase inhibitor because I want to give you a flavor and a taste of what an early drug looks like. 90% of drugs that we deal with do not make it to the FDA for consideration for approval. But I picked this one because it made a splash at ASH. And I think it's worth talking about. And then we're going to move to PV. We're going to talk about heptcidin and targeting heptcidin to reduce phlebotomy requirements. And then lastly, because we don't want to forget about ET, I'm going to highlight something that I think is an exciting move forward, which is vaccinations against CALR, which in reality also includes primary myelofibrosis and post-ET and MF myelofibrosis that are lower risk. So this is a slide I've shown before. How do MPN patients, or what do MPN patients want? They want highly effective therapies, ideally low toxicity. In our world, if you can give an oral agent, that ultimately is preferable over an intravenous agent that ties you into the cancer center. And then disease course modifying. And I use this in quotes because we often talk about it, but it's not always understood what that really means. To me, disease course modifying means that the natural history of your disease is altered in a favorable way. You're less likely to have progression of disease. You're less likely to die of your disease. And we're more likely to control your disease, whether it's in a remission or halted in its progression. We're changing the course of the disease. And that's really important to remember because you will hear me and others with good intention saying we have disease-modifying therapies. But what we really want are disease course-modifying therapies. And then obviously cure is the goal. And as we heard yesterday, right now the only curative therapy that we have for myelofibrosis is a hematopoietic stem cell transplant. So how do MPN investigators, we don't have the updated slides, right? I just want to make sure before I keep going because I did do this so that it would be, I'll keep going, but so how do MPN investigators get there? So mechanism-based agents, we use this term frequently. What does it really mean? It means that we understand what the drug targets are, that we're not just throwing a dart at a board and hoping that it sticks. And that there's preclinical data. And what does that really mean? That means that there's laboratory evidence of activity, typically in mice that are engineered to have a myelofibrosis phenotype because they have a mutation like a JAK2 mutation or MPL that's designed. And then we evaluate whether drugs that we want to use in the clinic can be used in these mice and whether it has effects that would, effects that would suggest activity. And then biomarker evidence of on-target effect. And what does that really mean? That means that we can sample the blood and bone marrow from treated patients in clinical trials, those are called biomarkers, and confirm that we're hitting the intended target, that the drug we're giving is actually doing what we think it's supposed to do, and that there's not off-target effects, that we really understand what we're doing. And then disease burden modification means, in simplest term, that one example is we can reduce the driver mutation level. So if you have a JAK2 V617F mutation and it's 80% before you start the therapeutic trial and then goes down to 40%, that may be considered disease burden modification. Now, whether that actually translates to disease course modification has to be proven within the context of a clinical trial. And I'm hoping to highlight this as we move into the study. So let's get into it. So the first one I'm going to talk about, and I'm biased. I'm acknowledging I'm biased. I'm discussing things that I really think, I personally think are moving the field forward. But I am picking things that have been advanced to phase 3 testing. This is one example. So we know that in patients with MPNs, they overexpress a protein called MDM2. MDM2 is a protein that binds and negatively regulates an extremely important protein or transcription factor called P53. P53 is the master regulator of cell fate. It affects the expression of many genes that tell our cells whether they should live or die in essence. So our cells actually know to commit suicide, something we call apoptosis, if they're triggered or induced to do so. And they are supposed to know when to do that if they are corrupted by bacteria, virus, or by cancer. And they do it all the time, and that's why we don't develop cancers all the time in large part. Now, the problem is that some cancer cells, like in myelofibrosis, develop mechanisms to avert those normal natural processes. And one of them is to express MDM2 at high levels. It binds P53 and does not allow it to exert its function, which is to tell the cell, die. You are corrupt, you are cancerous, you must die. But this protein overcomes that. So this trial is an example of exploiting the fact that we knew that MDM2 was upregulated. This is one example, but the furthest along in development. And trying to convince MPN cells over normal cells, and when I say MPN cells, I mean MPN stem cells, the original grandmother and grandfather cells that give rise to the disease, over normal cells, inducing those cells to die so the normal cells have a chance to recover. What I'm showing you here is not to overwhelm you, it's to try to paint a picture. So what you're looking at is different doses of this drug that were evaluated. This is in phase 1-2 testing. Different doses of the drug that were evaluated in patients, dosed 7 days in a row, every 28 days. So it's intermittent. You get a week of the drug and then 3 weeks off. And what it shows you is their profile of their mutations, what their cells express in terms of mutated genes that are highly prevalent in MPNs. So the top shows you what they look like before they started, and then the bottom shows the best response that they got on study. So this is not clinical responses. This is not spleen and symptom responses. They were there. We saw those. I didn't want to show that. What I wanted to show was what's happening at the molecular level. Are we changing the disease, and are we getting rid of or decreasing the abnormal cells in the bone marrow that cause the disease? And the answer is, to some extent, yes. If you see the color coding down below, if you focus in on orange and then like that rust color, those are the ones where there was a reduction of 20% of a VAF. VAF means variant allele fraction or frequency. That's the amount of mutation that they can assess in the blood. A complete reduction means below the limit of detection, which is shown here of the assay. And what you can see if you just scan across is that we are seeing that there are reductions, and even some cases, elimination of mutations, even what I would call high molecular risk mutations, mutations like ASXL1 that are known to be poor players and affect prognosis. So here's an example of a drug that's changing the composition of the cells, the malignant cells in the bone marrow. But what is more interesting to me than that is trying to correlate it with clinical effects. So what I'm showing you here is on the left is a graph that shows the best SVR. SVR stands for spleen volume reduction. We use it in all the studies. Spleen volume reduction, how much spleen was reduced? So if you go left on that x-axis, that's more spleen was reduced. And if you go down on the y-axis, that's best change in VAF. That's the amount of mutation. What the correlation is showing you, and that's a correlation, is that there was a correlation between reduction in driver mutation and reduction in spleen. Well, that's important. That tells us that mutation chart that I showed you may actually be clinically meaningful, that it correlates with spleen volume reduction. On the right, it's a different way of looking at it. So there's an enrichment in the patients who, in blue, or dark blue, I'm colorblind, so I can't really tell, dark blue, with those patients who had the greatest reduction in VAF compared to those patients who had less spleen reduction. Again, just a different way of looking at it. And even in the TSS, total symptom score, there was more patients who had a 50% or greater symptom improvement correlated with or enriched for patients who had reductions in their driver mutation. So correlating spleen reduction and symptom improvement with driver mutation. We know that in MPNs, particularly myelofibrosis, this was all myelofibrosis patients, that they have aberrant trafficking of their stem cells, meaning that when you have myelofibrosis, your stem cells that should reside very happily in the bone marrow, for complex reasons I won't get into, start mobilizing. They start circulating in the blood. And it's very easy to pick them up off the blood. In fact, that's how we actually look at stuff, because an aspirate from a bone marrow biopsy is inaspirable. So the blood tells us the picture for the most case. And you can measure how many of these CD34, these are immature cells, these are the stem cell compartment. It's a mixed compartment, but a stem cell compartment. And we can see these circulating. And what we saw with this drug was that we potently reduced the circulating abnormal cells. So all of a sudden, all of these abnormal cells that are trafficking in the blood are drying up by almost 90% in some cases. And that correlated, again, with spleen volume reduction. So another biomarker that correlates with a clinical outcome that matters in large part to patients and drug development, which is spleen volume reduction. And we saw bone marrow fibrosis reduction. So in the dose that was the winning dose, which was 240 milligrams for 7 days in a row out of 28 days, about a third of the patients had a reduction in bone marrow fibrosis. Now, I will caveat, if you look at ASH, the American Society of Hematology abstracts, in almost every drug, about a third of the patients have a bone marrow fibrosis reduction of at least 1 grade. And that sounds exciting, and I will admit, I'm one of those physicians, when I see it happen with my patients, I do get excited, and I do convey that in a positive way. But I will also, in a fair and balanced manner, point out that we don't always know what that actually means. Does that actually mean the patient is going to live a longer, happier, better life? Well, we need to correlate that. So in each case, we need to understand, is reducing fibrosis in the bone marrow, does it have meaningful impacts in patients? Because if you're an MF patient and we reduce your fibrosis, but nothing else improves, your blood counts don't improve, your spleen doesn't improve, your survival and symptom improvement doesn't improve, then I'm not sure it's really meaningful. So the data inspired the Boreas study. This is an ongoing randomized phase 3 clinical trial of patients with advanced myelofibrosis who have failed ruxolitinib. And that's a theme you'll notice. Most studies, or the majority of studies today, not all studies, are evaluating therapies where you have failed the first line of treatment, usually Jakafi. And then you get either the single agent, a monotherapy as a salvage therapy, or you combine another active agent with Jakafi to try to improve the response. So this is an ongoing phase 3 study, which I would pay attention to, because I do think, and I'm not alone, I think many people would agree that this is a very active drug. What is the liability of a drug like this? I took the slide out. It's GI toxicity, so gastrointestinal toxicity. So we've heard a lot about toxicities through these 2 days, and we heard a great talk just now about how to mitigate that toxicity with complementary integrative approaches. So we have to get better as a field of delivering drugs. Again, if you remember my initial slide, effective drugs with low toxicity profile. But of course, our appetite for toxicity is directly related to our aspiration for the drug. A drug that can provide longevity and survival may be a drug where some GI toxicity would be tolerated versus a drug where that doesn't hold the promise. So we'll have to see what that looks like. I'm going to move on to telomerase inhibition, because this comes up a lot. And there was even a question yesterday from a gentleman on this side about imetelstat. So telomerase is an enzyme. And you'll notice a common theme as I talk about these drugs. It's an enzyme that's overexpressed in malignant cells, particularly malignant stem cells, constitutively, meaning all the time, whereas it's only transiently expressed in normal hematopoietic stem cells. Why is that important? That's a window of opportunity to exploit the fact that there's a difference in the biology of the malignant stem cells and the normal stem cells. And what does telomerase do? It's an enzyme. What do enzymes do? In this case, it adds telomeres, or DNA repeats, to the ends of chromosomes. Every time your cells divide, any cells divide, they lose these ends of the chromosomes, these caps, and they get to a critical threshold where they can no longer replicate, and they induce, the cell essentially dies. So cancer cells have ingeniously gotten around this fact of life, and they overexpress this telomerase, so they're always adding these caps. They never get that signal to die. It's almost like an immortal feature of the cells. And we said, well, if that's true, then we should try to target it with a drug that inhibits this enzyme and renders these cells mortal. and removes that aspect of immortality, the ability to add these telomere repeats. And that's what imetelstat is. It's a small molecule inhibitor that effectively knocks down this enzyme and does not allow it to sustain these malignant stem cells. So credit goes to Dr. Teferi, who was really the first person at Mayo Clinic in Rochester to do a pilot study with this drug in patients with myelofibrosis. This ultimately got published in the New England Journal of Medicine. And what he showed was that out of 33 patients with myeloid malignancies, there were a number of patients, 7 in which had complete or partial remissions. This means that their bone marrows looked normal, they had molecular responses, and this was unusual. Outside of transplant, we did not really see this. Now, the drug was also associated with a lot of myelosuppression, low blood counts, but in most cases, those blood counts did recover because the drug is dosed intermittently. But this got a lot of attention, and as things do, when they get attention, they move on to larger studies where we try to see over multiple centers, can we replicate that? Can we see that again? So we did a study, a phase 2 study, randomized study, comparing, it wasn't really comparing, looking at 2 doses of imetelstat, this telomerase inhibitor, IV, every 3 weeks at 9.4 milligram per kilogram, the high dose. That was the dose Teferi used. And then a lower dose that might have been a little bit less myelosuppressive, we thought, 4.7 milligrams per kilogram. And we wanted to see, and if you look there, what was the co-primary endpoint? Spleen and symptom. Spleen and symptom. So what did we see? And I'm really distilling this down, so you have to bear with me. I'm going through a lot of data, but what I'm trying to do is just hit on the highlights and the important points that I want you to walk away with. Well, at the top, you look at the median overall survival. And if you focus on the 9.4 milligram per kilogram arm on the right, you'll notice that the median overall survival was 28 months. It is, and at the lower dose, it was 19 months. So it looked like there was a survival benefit at the higher dose. Now, if you look at 5 independent studies, all retrospective in nature that have been done, outside of this study, the median survival of patients with myelofibrosis who have to come off ruxolitinib is somewhere between 12 and 15 months, median. So if you're a myelofibrosis patient out there listening to me, you have to understand median means the middle person. I'm not telling you what your survival is going to be, but we know that that is concerning. So we're looking for drugs that can improve the survival. Now, the problem was the study that we constructed was looking at endpoints that are common, spleen and symptom. If you look at the spleen and symptom endpoints, well, the symptom endpoint was about 30%. That's actually equivalent to second-line JAK inhibitors, but the spleen endpoint was not that impressive, 10%. So the initial thought was, oh, well, this drug may not be a drug that has a lot of benefit until we start to really think about it and say, well, that survival benefit is intriguing and might be very valuable to patients. And there was reduction in driver mutation of 42% and bone marrow fibrosis reduction of 43%. It was doing something. So we started to look more carefully and trying to balance it out. It's also myelosuppressive, so it's a pretty well-tolerated drug, but it does reduce blood counts. Now, it's given every 3 weeks, so the counts generally come back and you can continue treating, but there is some degree of myelosuppression, low blood counts. It didn't result in the study with significant effects like being admitted to the hospital with fevers or having significant infections. There were some patients, but not many. But what we started to see was that there was, again, I'm always trying to correlate biomarkers with response. So what you can see here is that at the 9.4 milligram per kilogram dose, there was 41% or 42% of patients had a reduction in their bone marrow fibrosis. And if you look at the correlation on the right of those survival curves, those are classic survival curves, there was an improvement in survival if you had a reduction in your bone marrow fibrosis. So here we're showing that the reduction of fibrosis may matter, at least with this drug, because it looked like there was an improvement in survival. No matter what dose you got, if you had reduction in fibrosis, your survival appeared, in general, in a group of patients, appeared better. If you had a reduction in your VAF, your driver mutation, so here you can see the majority of the patients that enjoyed that reduction were in the 9.4 milligram kilogram arm. That's the high dose. Again, if you look at that red line, it looks like there's an improvement in survival if you have reduction in your driver mutation. So reducing the burden of disease improves the outcome of patients, both by fibrosis as a measure and by reduction in the driver mutation. Well, that got attention. So we moved the study into a phase 3. This is an ongoing randomized phase 3 of imetelstat for patients with myelofibrosis after ruxolitinib failure. And it randomizes the patients, and that's the thing you have to understand about phase 3 studies. You're randomized. It's done by a computer. Your physician, no matter how much they love you, they cannot dictate what drug you get. It's random. It's a computer that spits it out. You're randomized to the drug or best available therapy, in which your physician would assign what therapy that's appropriate. If you look at the outcome here, this is the first study that I'm aware of that looks at survival as an outcome. So moving beyond the spleen and symptom, which are not unimportant, but looking at survival, which is obviously important. So a survival endpoint in a randomized phase 3 study. To me, this is a huge milestone, something as a group of investigators we should be proud of, because we're trying to really move the field forward from one that addresses spleen and symptom and hopefully adds the additional and most sought after benefit of improvement in survival. So we'll find out. That study is ongoing. Now, to something earlier on, to give you a sense of where this all starts, this is an example. This is a study that caught my attention at ASH for no other reason than it was new. And a lot of the studies we talked about at ASH were important. There were a lot of follow-up studies. But here was a study of a drug called TP3654. And what you'll notice is that when drugs are still early on in development, they don't have these complex names. They usually have letters and numbers, and only if they pass a certain mark and the company thinks that there's promise, they will pay enormous amounts of money to people who actually develop names for these drugs with approval from the FDA. So this drug is not quite there yet, but I suspect it might get there. So this was a study done at a number of different institutions with an oral PIM-1 kinase inhibitor. And what's a PIM-1 kinase inhibitor? Well, like most of these drugs, these are drugs that are small molecule inhibitors, and they inhibit elements in a cascade of signaling molecules that are inappropriately activated in myelofibrosis cells. And you'll notice on the top of this cascade is JAK. And everyone at this point is somewhat familiar, particularly by day 2, of the idea that the JAK-STAT signaling pathway is, no matter what mutation you have, is activated. It's hyperactivated, inappropriately turned on. And as a consequence of that, we have inflammatory consequences, spleen, symptom, and abnormal blood counts, and a whole host of other issues. Well, the PIM-1 kinase inhibitor fits in here because it hits that PIM-1 in green selectively. There are different PIM kinases. In the past, we worked with drugs that were pan-PIM kinase inhibitors, and they caused a lot of low platelet count. So although we thought they were promising, they had no future because we couldn't deliver them. Well, these guys have a PIM-1 kinase inhibitor that's selected for PIM-1, and you can see downstream from that there are a lot of things that it hits, and you may not be familiar with these names and these things, but I can assure you that these are aspects of the disease that we've been trying to target for quite some time, whether it's TGF-beta, which induces fibrosis and negatively regulates normal blood cell development, so getting rid of that and downregulating that's important, or other drivers of the disease. And you'll see BCL2, and I think Naveen will probably cover BCL2, which is an important protein which allows these malignant cells to persist, and we want to change that dynamic. So here I'm trying to show you something that I think is really key. And this I show you because I want to instill confidence in those of you that move forward in a courageous move to join a clinical trial. To do a clinical trial, you have to have a certain degree of belief that what we're doing is based on a long, often a very long amount of research that goes from the lab, eventually through animals, and then into humans, into brave humans. So here's an example of the fact that you need to have the preclinical data and believe that the target makes sense. So here is an example of if you have an engineered mouse to have myelofibrosis, in this case with the MPL mutation, but it could be with any mutation, and then you genetically knock out the PIM-1. So the people in the lab, the Dr. Nangalias and the others that drive all of this, they can manipulate the genes in mice, and they can turn off genes, turn on genes. They can turn off this gene, PIM-1. And they look, well, what does it do if you turn off a PIM-1 gene in a mouse that is effectively has myelofibrosis? Well, you can see and if you follow those little pictures, those are of the bone marrow, that the fibrosis, so in the WT is wild type. So in the myelofibrosis mouse, there's a lot of fibrosis in that mouse. If the KO knockout, if you knock out that gene, like as in targeting it, all of a sudden that fibrosis is gone. Now, on the right, if you knock out PIM-2, which is not relevant to this, it doesn't really change things in a significant way. So this proved that knocking down PIM-1 in a mouse that is engineered to have myelofibrosis looks like it does something fundamental to the disease. It gets rid of the myelofibrosis. They also saw that the platelets didn't really drop in these mice, and that the mice lived longer. And it looked like this was a rational, we use rational a lot, a rational drug to take to the next step. Well, they did. So then they took it and they started treating mice with their oral drug. They said, well, this PIM1, if you knock it out, it makes sense. Let's try treating the mice with our PIM1 kinase inhibitor. And what you can see, if you see, those are it looks weird, but those are mice spleens. Little mice with big spleens, and that's what a murine model of myelofibrosis looks like. When you give the vehicle, which means nothing, a sham drug, those spleens are large. And then if you give the TP drug, that's the PIM1 kinase inhibitor, you can see the spleen gets a lot smaller. So you can imagine in a human who has a big spleen, the spleen will get smaller. If you give ruxolitinib as a control, the spleen gets smaller. So that tells you that the model makes sense, but maybe not as small as the PIM1 kinase inhibitor. And then, as Naveen will tell you, it's all about combinations in the future. If you combine the two drugs, that maybe looks the best in terms of spleen reduction. And you can see that the mice had reduction or even elimination, I would say, of fibrosis in their bone marrow with the PIM1 kinase inhibitor. And their spleens got smaller, so you saw it up top, and they measured it and showed it on with the bar graph below. But look to the right, the survival. So the blue line are the mice who were fed the PIM1 kinase inhibitor and Jakafi, and they continued to live. Whereas the mice who got vehicle, who didn't get anything, that's the natural history of a myelofibrosis mice. They die from the disease. So it looks like the drug hits the target, it looks like the drug improves aspects of the disease, and it looks like the drug prolongs the survival of mice. Well, that's enough to take it into humans. There's more to it, but basically that's enough to take it into humans. So here's the phase 1/2 study that was presented at ASH in patients with myelofibrosis. Again, you'll notice the same theme, who were either relapsed, refractory, or intolerant to Jakafi. And they got this PIM1 kinase in different cohorts of patients in a dose escalation schema, which is pretty standard. And you'll notice in key eligibility down below, we tend to treat patients who have higher risk myelofibrosis. And the FDA almost always insists on a platelet count of at least 25,000 for safety reasons. So a number of patients were enrolled in this study. And I show this just to point out that this was a pretty well-tolerated drug. When you look at papers or if you're ever evaluating whether you want to enter a clinical trial, always look at grade 3-4 toxicity. That's the significant grade toxicity. What you can see on the right is that there was minimal grade 3-4 toxicity. Now, if you look at grade 1-2, there is some diarrhea, nausea, and vomiting. It was mostly transient in the beginning of the cycles and really didn't cause a lot of problems or discontinuation of the drug. So this was a pretty well-tolerated drug. And there wasn't significant thrombocytopenia. That is one of the biggest limitations of most drugs we evaluate. They knock the platelets down. You can't deliver the drug effectively. Well, this drug didn't really do that. And here I show you graphs where the platelet count remained pretty stable throughout the dosing period. The hemoglobin remained quite stable throughout the dosing period. And the neutrophils, which are often elevated, actually came down to more of a normal range. And there were spleen responses. Now, this is after ruxolitinib. These patients have often big spleens, difficult to treat spleens. But in just 8 patients, small study, you can see the columns going down is what you want to see, is reduction in spleen volume. That's a positive response. So you can see that there were patients, 2 in fact of the 8, that had a spleen volume reduction of 35% or better. And 35% is somewhat of a meaningless number, but it is a regulatory endpoint. It's what the FDA wants to see, because it approximates about a half of a 50% reduction by palpating someone's spleen. Symptoms improved. You can see that here. So 2, 3, 4, 5 out of the 8 had significant symptom improvement. This is after ruxolitinib, so the patients were quite symptomatic. And here I show you the heat map. Again, not to overwhelm you, but to bring up a point that was highlighted in yesterday's talk. We know it's a very inflammatory disease. In fact, one of the physician patients yesterday asked about inflammation. Here we go, inflammation, inflammatory disease. Does this drug do what we think it's going to do based on that diagram I showed you, that cartoon of where it fits into the biology, the pathobiology of the disease? And the answer is yes. If you look at all the green, that means significant reduction in inflammatory cytokines. With this drug, there was significant reduction in inflammatory cytokines. So we were suppressing the cytokine state that exemplifies myelofibrosis. So that's a biomarker. So stay tuned. We'll see where that drug goes. But again, I showed you some late-stage drugs in myelofibrosis that I think are promising, that I think in a relatively short period of time will result, and may even in a quick time even gain approval. That might be additional drugs for our armamentarium. And then I showed you an early phase drug, one to show you that there is hope and that these things continue to move forward in a rapid pace. Now, moving on to PV. So PV is like myelofibrosis, but it's not like myelofibrosis in the sense that you have too many red blood cells, and we often try to get rid of the need for phlebotomies, and we know through an Italian study and studies done previously, we know that controlling the hematocrit as one indice less than 45% reduces the risk of having clots. So if you're a PV patient, you're very well familiar with the fact that we stare at the CBC, we look at 45%, and then we dictate whether you get a phlebotomy or not. But we also realize that, that there's derangement of iron and red cell production in patients with polycythemia vera, and that in polycythemia vera, there is a low hepcidin state. Let's see if this works. Yeah, a low hepcidin state in which iron is supposed to be taken up by your enterocytes in your gut, and then it's released and stored in what are called macrophages in the bone marrow, and then they are released and provided for red cells to be made. When you have PV, you essentially develop an iron deficient state. Your ferritin, which is one of the iron numbers, is very low, and you don't have iron readily available because either you're overproducing red cells to an extreme extent and or you're having phlebotomies, which essentially induces, by intent, iron deficiency. And we know that if you can give, and hepcidin is low. Hepcidin is an inflammatory protein that comes from the liver. It's driven by inflammation, and we know that hepcidin can bind a ferroportin, which are these channels that allow iron to get out of cells, and it can internalize the channel and keep iron from being released. So what does this effectively do? So essentially, it allows for iron to build up where it should in the bone marrow, but it actually chokes off the bone marrow so that you can no longer have access, or the red cells don't have access to iron. So it reverses the iron deficient state, and it eliminates or reduces the amount of iron that's available for red cell production. And that's what it essentially does. And for that reason, a company developed a drug called PTG-300, and this drug, rusfertide, that it's now called, is a mimetic of hepcidin. Hepcidin we saw was low in PV, so we said, well, maybe if we give this drug as a subcutaneous injection, it would control the distribution of iron and choke off the bone marrow so that PV patients weren't making red cells. Well, this was the study that was designed, and just simply, you give the drug every week as a subcutaneous injection. This is different than interferon, very different. But you give the drug every week, and what did we see? Significant reduction in the need for phlebotomy. So basically, you eliminate the need for most phlebotomies in most patients. And this is whether you were on hydroxyurea, Jakafi, or whatever, or nothing. In either case, it reduced the need for phlebotomy, and it kept the hematocrit well controlled under 45%, and it normalized the red blood cell count. It didn't really do anything for platelets and white cells. Wouldn't expect it based on the mechanism of action. And then there was even a hint that maybe the symptoms got better as a result of resolving the iron deficiency, if you look at stuff like fatigue, concentration, and itching. So this is a drug that is in late-stage development. And it was very well tolerated. Some injection site reactions, but really there were no grade 3/4 toxicity. It was a pretty innocuous drug for the most part. And this is what is now ongoing, the Verify trial. This is looking at rusfertide added to whatever ongoing therapy you have for PV with the idea of eliminating phlebotomy. So this is great for patients who have excessive phlebotomies, particularly patients where phlebotomies may be painful or uncomfortable or frightening, and this may be one way of eliminating phlebotomy. Again, very different than interferon, just to be very clear. Sometimes they're confused. Interferon is also an injectable that has much deeper anticlonal and stem cell effects. And there are a lot of companies that have jumped on this bandwagon trying to exploit different mechanisms that also lead to this low hepcidin state. So it's spurred a lot of clinical trials, and many of you may see this and be presented with this even in your own practice. So to end with, I'm not going to forget about ET, and I'm going to highlight the CALR vaccine. So why CALR vaccine? So CALR, and this is an initiative that we have at Mount Sinai with funding from Parker Institute, the MPN Research Foundation, and the Leukemia Lymphoma Society. CALR is expressed, so JAK2 and MPL are intracellular. If you are a CALR patient, your mutated CALR is expressed on the surface of the cell, and it interacts in an intimate fashion with the MPL or thrombopoietin receptor. So knowing that, just knowing that all of a sudden changes the game. Now we think, well, this abnormal protein is on the surface of the cell. Maybe it could be targeted by immunotherapeutic approaches. So that is, and I'm skipping some things, but for the sake of time, I want to kind of get there. And if you look back, there's a lot of data that would suggest that, CALR is expressed on the surface and it is important for the clearance of apoptotic cells. These are the dead cells. And therefore, it might be a target or an epitope that you could develop an immune therapy for. And we know that the mutations in CALR, and there's different mutations, some of them result in a 52 base pair deletion, that's type 1, some of them in a 5 base pair insertion, that's type 2. Irrespective, though, there's an abnormality in the C-terminal peptide, so the one end of the protein, that makes it distinct and looks different than the normal wild-type calreticulin, and it also explains its function or misfunction. So to take it aside for a second, so some years ago, I jumped on the PD-1 bandwagon. So if you have other, if you've paid attention to other cancers or you watch TV, you see ads for Keytruda. Keytruda is a checkpoint inhibitor. It's a type of immune therapy that tries to reinvigorate T cells by turning them back on, because there's a concept that malignant cells can actually exhaust and turn off T cells. And T cells are fundamental parts of your immune system that should recognize cancer cells and do, usually on a regular basis, and gets rid of them. That's why we don't have cancers mostly. But in patients with myelofibrosis, the thought was maybe, like in other cancers, this pathway is active and the cancer cells are turning the T cells off. And there was reasons preclinically to think that because we had evidence that the pathway was upregulated in myelofibrosis. And we took this drug, Keytruda, or pembrolizumab, into the clinic. I did the study with Gabby Hobbs, who's up in Harvard in Boston. And we treated a bunch of patients that had really advanced myelofibrosis and even some that had acute leukemia. And the point of the slide was it didn't work. It didn't work. So you might be wondering, well, why the hell are you talking about a slide and a drug that didn't work? Well, we learned something from the study, which I think translates nicely into the CALR vaccine. What we learned was when we did the sampling of the blood, the biomarkers I told before, so even though the clinical responses weren't there, we didn't just throw it away and say, oh, we didn't learn anything. We took the blood from the patients that were brave enough to go on this study, and we learned from that blood that we were, in fact, turning on the T cells, and there was a T cell response that looked like it was against something specific. We couldn't figure out what it was, but we believed it was against something that was myelofibrosis specific, maybe even the CALR mutation. In fact, we paid very close attention to what those CALR patients looked like. And although the clinical responses weren't there, it told us that this was a mechanism that made sense, that was rational. So it empowered us or emboldened us to say, well, we got to try a vaccine in the CALR patients, and this is what it's going to look like. So the vaccine is given every 2 weeks for the first 4 doses, and then every 4 weeks for 6 doses. And the concept here is we're going to aggravate and agitate the immune system to create an immune response to the CALR mutated expressing cells, the myelofibrosis and or ET cells. So this is not a direct therapy. It's not a small molecule inhibitor. We're not targeting the cells directly. We're trying to encourage patients' immune systems to do what they have failed to do. Now, the problem is, and for those Europeans in the group, they'll say, well, John, we did this in Europe. We were ahead of you. And that is true. They did. So there was a study in Europe, as we were getting this together. It took 3 years just to get the study FDA sanctioned so we could do the trial. The Europeans were ahead, and they did it. They did a CALR vaccine study. And guess what? It was negative. It was negative. Okay, so you're going to say, John, where are you going with this? Because this is going nowhere. But it is. It's going somewhere. So what they saw was, again, they did biomarkers, and they saw they were activating the immune system, but it didn't translate to clinical benefits. So we teamed up with our outstanding immunologists, and we said, well, how can we learn from that and do better? Because we don't want to waste patients' time, energy, and lives. So what we did was they figured out, I don't know anything about this, but they figured out that the better way of doing this was to use multiple peptides that overlap, that would in theory give a much stronger immune response, and importantly use adjuvants to stir up the immune system that were more potent and immune enhancing. So we're using this poly-ICLC and KLH instead of the montanide, which is what they used in the European vaccine. So we think because of these reasons that this vaccine will hopefully be more potent, add on what they saw, but actually translate to clinical responses. So that's for ET patients who are higher risk or low risk PMF patients. So I try to cover MF, PV, and ET. So in summary, I think there are exciting monotherapy, and Naveen will talk about the combination therapies that are really exciting, that are ongoing in MPNs. The trials are built on laboratory data. It supports a rational mechanism. That is really important to remember. Trials sampling blood and bone marrow from treated patients prove the drug is on target and killing MPN cells. That is essential. Approaches to limit MPN stem cells from expanding and encouraging them to commit suicide, that's apoptosis, are promising. I really believe that's the future. Choking the bone marrow supply off of iron with hepcidin mimetic like rusfertide can remove the need for phlebotomy in PV. Turning on P53, if you meet my mentor, Ron Hoffman, he thinks it's all about P53, and he may be right. So turning on P53 in any particular way, MDM2 inhibitor is one way, may be a very effective way in killing MPN cells. Redirecting the immune system to naturally get rid of CALR-mutated cells in ET and early PMF is exciting and on the horizon, and we're doing it now at Sinai and other places. And clinical trials today bring wide access to better drugs tomorrow. So if you have the opportunity to get involved in a clinical trial, I'm biased, but I would highly, highly recommend considering it, because that is where things get better. And here's a picture of where I sit on a daily basis at Mount Sinai, right next to Central Park. So thank you very much.
Wow. That's drinking from a fire hose. That's awesome.